Hello, good afternoon. My name is Fouad Baroudi, and I am a pediatric otolaryngologist. I practice at the University of Chicago, and I'm going to share my screen and talk to you about prevalence and epidemiology of chronic rhinosinusitis. All right, so we're going to talk today about prevalence and epidemiology of chronic rhinosinusitis. And I will start by saying that I have no significant disclosures related to this topic. This is a lot of this data I got by reviewing the ICAR document, which is related to rhinosinusitis, which was published in the early 2020s. And you might want to reference to go back to that to look in more detail. There's also the EPOS document, EPOS 2020, which is the European Position Statement on Chronic Rhinosinusitis and Nasal Polyposis, which is also very useful in that regard and has an exhaustive review of the literature. So let's talk very briefly. The main purpose is chronic rhinosinusitis, but I'll mention a few points about prevalence of acute rhinosinusitis. It is one of the most commonly diagnosed diseases in the outpatient setting, and it accounts for like 2 to 10% of primary care and otolaryngology visits. I will show you in a little bit data about pediatrics, which also touches upon that period. The estimated incidence is from 1.4 to about 9%, depending on the study methodology and the population. And the bottom line is that people really don't know how many of these are acute bacterial rhinosinusitis, but it is thought that ABRS accounts for between anywhere from 0.5% to 2% of all viral upper respiratory tract infections. And you all know that this is how, initially an upper respiratory tract infection is a viral rhinosinusitis. And if it persists for more than 10 days or it's starting to get better, but then gets worse within that 10-day frame, then we presume that it switched to bacterial and we treat it as such. And the incidence of that is about 0.5% to 2% of all colds. Enough said about acute disease. Let's talk a little bit about chronic rhinosinusitis. You all know the definitions, and a lot of these studies of prevalence are based on questionnaires that look at symptoms. So clearly the duration has to be 12 weeks or longer, and that's for chronic disease. And you have to have, for most definitions, will want to see nasal discharge and nasal obstruction as the predominant symptoms, and other symptoms would be hyposmia, facial pain or pressure, or cough, especially important in pediatric chronic rhinosinusitis. In addition to symptoms, which unfortunately a lot of the data rely only on symptoms, but in addition to symptoms, most guidelines suggest that we need objective criteria to quantify sinusitis or to document the presence of disease beyond symptoms. And that would be either nasal endoscopy or CT showing evidence of inflammation in the paranasal sinuses, or seeing pus coming from the sinuses or the osteomial unit by endoscopy. And clearly, as we all know, CRS is divided into with and without polyposis based on whether or not we have polyps on clinical exam. So let's look at a couple of studies in children. This is a study from Sweden looking at almost 3,000 16-year-olds from a birth cohort in Sweden. And the incidence, and then they brought people with the suspicion of CRS and actually examined them and used both symptoms and objective criteria on endoscopy to diagnose CRS. And in these patients, rhinitis prevalence was about 34%, allergic rhinitis 26%, and chronic rhinosinusitis only 1.5% of the patients. And the panel on the right basically shows you that the quality of life in the patients with sinusitis was worse than in the patients without rhinosinusitis, which is well understood. We know that chronic sinus disease affects quality of life adversely. So the incidence in that population, which was actually very rigorously studied, was about 1.5%. If you look at another study based on questionnaires and ICD-9 codes, looking at ambulatory surveys, both ambulatory medical care survey and hospital-based ambulatory survey, looking at the years between 2005 and 2012, patients up to 20 years of age, and they looked at the total number of visits with an ICD-9 diagnosis of CRS. And as positive controls, they had ARS incidence, upper respiratory tract infection, chronic rhinosinusitis, and otitis media, which are clearly important in the pediatric population. They had about 2 billion visits, and the data is seen all the way to the right in this table. If you just to rehash, acute rhinosinusitis was only 0.6%, so not very commonly presenting to an acute care ambulatory facility. Chronic sinusitis, about 2.1%. As a positive control, the most common presentation was for upper respiratory tract infections at about 8%. Allergic rhinitis was 2.6%, and otitis media was a little higher, right below URIs at about 7%. So that puts you in context. So basically for CRS in kids, the incidence, depending on the study, is like between 1.5 to like 2.5%. Now let's look at adults. This is a study from Harvard. Actually, the second author is also participated in the study I just showed you, looking at adult chronic rhinosinusitis symptoms. So this is contrary to our definition that we'd like to stick to. This was an estimate of prevalence based on symptoms. And this was data from the NHANES survey between 2013 and 2014. And the NHANES survey has a taste and smell module. So people looked at a lot of visits for adults with symptom and looked at symptom prevalence analysis. So basically, if you look at the number and then the percent of the visits, reporting these symptoms, 8% reported smell problem, 6% reported nasal blockage, 2% reported sinus pain, and 1.1% reported discolored mucus. Now, if we go back to our definition, we need at least 2 of these symptoms to make the diagnosis based on symptoms only, which has its limitations, but that's what this study does. So if you look at patients who had either 2 or 3 symptoms, the incidence was about 2.1%. So the chance of any of these visits being related or being true chronic rhinosinusitis by symptoms only, by having at least 2 or more of these cardinal symptoms, was about 2.1%. So in this study, the numbers were about 2.1% of the patients presented with that. Now let's look at another study that actually shook it up a little bit, looked at symptoms, but also looked at race and ethnicity and some other factors, gives you some idea about some disparities that exist in clinical care. And again, this was all based on surveys. So the first one is a national health interview survey from 2009. And this looked at adults that were told they had sinusitis during the past 12 months. So you can sort of understand how this was not a very accurate reflection. But that said, we'll look at the data. They also self-reported race, ethnicity, insurance status, medical specialist visitation, surgical procedures, inability to work because of their health, and delays in medical treatment due to cost. So I'll show you that data in a second. And when they also looked at national ambulatory medical care surveys, similar to the study I showed you in kids before. So these were data from ambulatory medical care surveys. And this looks at detailed information regarding patient visits to physicians, emergency departments, and outpatient facilities. And a patient in this set of data was considered to have CRS if there was a physician ICD-9 code indicating chronic rhinosinusitis. So a little bit more reliable than the first survey where adults were told they had sinusitis. So at least here a physician was coding this as chronic rhinosinusitis. So let's look at their data. So they had a total of about 27,000 US residents looking at that survey where people were told they had sinusitis. And they had the large proportion were whites. The next number was African Americans. They had fewer Hispanics and Asians. And the number of patients with the diagnosis of chronic rhinosinusitis was 13.8% in African Americans, 13% in whites, and then a little bit less in Hispanics and Asians, about 7 to 8%. Now, a couple of things they looked at. They looked at inability to work if you had sinusitis versus if you did not have sinusitis. And clearly, across all races, there was a higher proportion of patients who were unable to work with sinusitis, talking to the negative impact it has on quality of life and productivity. This looked a little bit about some health disparity issues, showing that Hispanics and African Americans were the 2 groups that were most likely to not be insured. And finally, looking at who among the groups went to a medical specialist or underwent surgery for CRS, looked like the white population was the most, followed by African Americans, and smaller proportions for Hispanics and Asians, especially when it came to surgery, which is the light gray bars, which makes sense. More people saw a specialist than underwent surgery. That doesn't surprise me. Now, when you look at the ambulatory care surveys, CRS accounted for an estimated 20.3 million of 902 visits, which was about 2.3%, in line with the previous one that I showed you, about a 2.1%. And the frequency of CRS physician visits was similar across race and ethnic classification. So whites, African Americans, Hispanics, Latinos, or Asians all had about the same percent of visits ascribed to a CRS ICD-9 code. So again, this is slightly more realistic pattern. About 2 to 3% of these patients were likely to have a diagnosis of CRS. So it gives you an idea about like how likely. Remember, both of these were surveys. None of these had a documentation with either an endoscopy or radiology of actual disease. This was a third study that looked at nasal and sinus symptoms of chronic rhinosinusitis in a population-based sample. So they looked at the Geisinger Clinic, which is a health system serving 45 countries in Pennsylvania, and they looked at a CRS symptom questionnaire was mailed to about 24,000 primary care patients. And they asked specific symptoms related to CRS, and they categorized these cases into 4 unique subgroups based on the EPOS criteria for CRS. Obstruction and discharge was present in all the groups, and it was only obstruction and discharge. It was obstruction and discharge with smell loss, obstruction and discharge with facial pain, and then obstruction and discharge with both smell loss and facial pain and pressure. So let's see these numbers. So estimated overall prevalence was 11.9%. So this also went by symptoms, but it was much higher than the previous 2 prevalences that I showed you, which were 2 to 3%. So this shows a prevalence of about 11.9%. And you will see that the highest prevalence was in patients between 50 and 59 years, drops significantly as you get to 70 years and older, and it's pretty high also from the 18 to 49 years of age. And what these colors imply, this is all the patients that have obstruction and discharge. These are the patients that have obstruction, discharge, and facial pain and pressure, obstruction, discharge, and loss of smell. And the purple at the top was obstruction, discharge, and both pain, pressure, and sense of smell loss, smaller proportion. So the majority were, nasal obstruction and discharge with pain and pressure. Just an idea of where these patients spread out by symptomatology. Now, this is a study that went a step further. Remember, all the studies that I showed you earlier were based on symptoms. So this is a study that actually coupled symptoms with radiologic evidence of disease. So this was a study out of Europe, looked at subjects who underwent a CT or MRI scan of the head for any non-rhinologic indication, and they filled an EPOS symptom criteria questionnaire. And they they scored the scans according to the Lund-Mackay system. And then they had epidemiologically based CRS based on symptoms according to EPOS, and clinically based if they had the symptoms but also had a positive CT scan or MRI. And this is the data. So they had 834 subjects. Mean age was 53, 63% were female. And 107 of these had epidemiologically based CRS, which means they had clinical symptoms supportive of the diagnosis of chronic rhinosinusitis. And if you look at those patients, 50% of them had an abnormal scan, be it mildly abnormal or significantly abnormal, and 23% had a significantly abnormal scan, where the Lund-Mackay score was above 4. Remember, there's a study from Bhattacharya published a while back looking at CT scans and suggesting that a cutoff of about 4 on a Lund-Mackay score, above 4 was suggestive of sinusitis, under 4 was really not that suggestive. And that's, I think, where the number 4 cutoff came from. Now, the prevalence of clinically based CRS in this study was 3% if you were conservative and you wanted them to have significant disease on the scan, and 6% if you took any abnormality on the scan to mean sinusitis. So again, by symptoms, it was about 12%, but if you coupled that with objective evidence of disease by scan, At most, it was 6.4%, and the more conservative estimate was about 3%. Again, all these numbers, with or without radiology, hover between 2 and 10%, basically, if you look across all studies, with a few above 10%. Now, what were your increased odds of having a score above 4, meaning, pretty rigorous definition of disease? Nasal obstruction increased the chance by about twofold. Rhinorrhea, loss of smell, female sex, smoking, allergic rhinitis, and waking up short of breath in the past 12 months were all symptoms that correlated appropriately and predicted an increasing chance of having a significant abnormality on the CT scan, suggesting true sinus disease. So these are things to keep in mind. Clearly, loss of smell makes sense. Rhinorrhea and obstruction makes sense. Smoking and allergic rhinitis makes sense. I think, females struggle with this a little bit more than males, apparently, or present with those symptoms. And I don't know what to make of waking up short of breath in the past 12 months, but that could be related to asthma in these patients also. So something to keep in mind about the burden of these symptoms in these patients. Now, what about, this was all comers with CRS, so it did not really differentiate without and with. This is a study that looks at the epidemiology of chronic rhinosinusitis with nasal polyps. A couple of quotes from around the world. European survey, 2.1 to 4.3% of patients recalled being diagnosed with nasal polyps. Again, this is recall, has bias. Using objective confirmation in a Swedish cohort, about 2.7% of patients were found to have nasal polyps. And among 29,000 subjects undergoing nasal endoscopy in Korea, their incidence of CRS with nasal polyps was about 2.6%. So it makes sense that probably the incidence of CRS with nasal polyps is 2-3%. The incidence of CRS in general, including nasal polyposis, is about a little higher, 6, 7, 8, 9%, depending on the studies that you look at. And finally, a piece of data. I mean, this day and age, it's important to talk about endotypes. This is work from Northwestern, which is sort of very interesting and gives you some idea about endotyping and the correlation to symptoms. They looked at 121 patients with CRS without nasal polyps, 134 patients with polyps, and they identify endotypes. These were all patients who underwent surgery, so they had tissue. And if the tissue was positive for interferon gamma, it was T1 inflammation or Th1 inflammation. If it had eosinophilic markers like ECP and charcoal-laden crystal galactin, this was T2 or Th2 type inflammation, which we all know correlates with allergic rhinitis and asthma. And if they had IL-17 signal, then this was Th3 type inflammation. And IL-17 is an important cytokine that promotes neutrophils. So this is more of an infectious type of phenotype. Now, they collected clinical parameters from these patients and they examined associations between the endotype and the clinical features. So what does the data show? So if you look at all CRS, T2, which is Th2, meaning IL-4, IL-5, IL-13, that's what dupilumab targets, basically, which is one of the biologics that's used very commonly. And also the IL-5 monoclonal antibodies target T2. And you see that in all CRS, almost 50% were T2, and there was a component of T2 in these mixed endotypes. So T2 was significant. And if you look at all CRS, there was some T2 in 72%, including T2 single as a single endotype, or T2 mixed with T1 and T3 endotypes, meaning all the markers were found. You had about 19% T1 and 22% T3. So T2 predominant in CRS as a group. Now, if you look at CRS without nasal polyps, T2 goes to a smaller proportion, but any T2 is still about 55%. So even without polyps, T2 is important. T1 is 21%, T3 is about 27%. So T3 becomes a little higher here, and T1 and T3 become a little higher, T2 becomes a little smaller. In CRS with nasal polyps, we all know that in Caucasians with nasal polyps, T2 is the huge phenotype, and that's why all these biologics are targeted towards eosinophilic inflammation. And you'll see that T2 accounts for a very large proportion. And any T2, meaning single T2 or T2 in the mixed endotypes, was about 87% of patients with nasal polyps, highest of all three groups. and T1 and T3 became much smaller. So that's important to keep in mind. And that sort of governs how you treat and how you think about therapy. Now, if you look at symptoms and what were the symptoms that were predominant with the different endotypes, you look at CRS without nasal polyps. Smell loss was more associated with T2. Headache and migraine were more associated with T2. Pus, which makes sense, was more associated with T1 and T3. Remember, T3 has IL-17, which promotes neutrophils, which tend to create pus. And T1 is also non-allergic inflammation. I'm not surprised that there was a higher proportion of pus in T3 and T1. Now, if you look at chronic sinusitis with nasal polyposis, smell loss is a big one, with T2, obviously. Headache and migraine is not as important in T2. It was more important in the patients without T2 inflammation. Really no significant sort of pus in T1 here, but definitely pus in T3, which is IL-17 driven. So again, even in some patients with nasal polyps who don't have T2, they have T3, you expect to see more purulent drainage. Just some idea to try to help you predict, use the symptoms to predict endotype. Clearly, endotype prediction is best based on a biopsy and looking for either message or the protein of these cytokines that we discussed. So this is a summary table from the ICAR document looking at estimated prevalence of rhinosinusitis without nasal polyps. On average, 5-6%. There were outliers with huge proportions and people with much less proportions. With nasal polyps is smaller, about 2 to 3%, as I showed you, and pediatric is small at about 2% also. And if you look at the endotypes, this is basically modified from that article that I just showed you. We just went over that. In all CRS, T2 is very important, and with nasal polyps, T2 is even more important. And you have smatterings of T1 and T3 across all endotypes and across all diseases. So this is sort of, I think, most of what you need to know about the prevalence of sinusitis that's up to date. And looking at EPOS and the ICAR documents would be very helpful. And provides a good summary for what we just discussed. And I thank you very much for your attention.